I hope you can hear me well, and welcome to all of you to this very first journal club on cardiac imaging. So I think it's really great to see that we have actually a lot of people connected. So I'm looking at the webcams there. A lot of scientists, imaging scientists, clinicians as well. I see you there. We have a couple of people with AI background, signal processing, people from industry as well. Good morning, Davide from Siemens. And we also have MR technicians, so which is really amazing. Welcome to all of you. So a lot of us are attending the meeting from Bordeaux, but let's welcome all together our friends from the CHUV in Lausanne. I see that we have quite a lot of people connected from Switzerland. Welcome to all of you. So my name is Aurélien Bustin, and I will be moderating this journal club on cardiac imaging and the coming sessions as well. And the goal of the meeting, and you've seen that on the flyer, is really to bring together a lot of people from different backgrounds, from different labs, different institutions, to really exchange on the topic of cardiac imaging. And hopefully we can create new collaborations all together on this specific topic. So before I start introducing today's speakers, I want to thank Laure Dangre from Lyric for the support and for the help. Laure, if you're here, show your hands so we can put a face on your name. So thanks so much, Laure, for the help. I can see you here. Please, to all of you, make sure your microphone is turned off during the talks. We'll have a little discussion after each talk. And if you don't have a microphone, or if you feel a little bit too shy to ask your questions, just type in your question in the chat and I will make sure to read them to all the speakers. So let's get started with the meeting. You see the flyer here, and it's a real pleasure to introduce the first speaker, Kilian Alliot. Kilian is a PhD student working at Lyric in the imaging team. And he is actually finishing his PhD. So we are very lucky that you accepted this invitation to present your work in such a stressful time. Thanks a lot, Kilian.
Oh, you're welcome.
And we are lucky because I think, correct me if I'm wrong, but we're gonna be the first to really hear about this study that you recently published in the Nature journal, so quite a big study. And you are gonna talk about a 3D high resolution MRI technique for the visualization of cardiac fibrofatty infiltrations. So Kilian, we're very much looking forward to your talk, and the Zoom floor is yours. Thank you.
Aurélien, perhaps you
Yes.
should remind people that this session is recorded.
Absolutely, it's recorded. Thanks, Matthias. Kilian, feel free to share your screen. Thanks.
Is it good? Do you see
Perfect.
anything? All right. So good morning, everyone, and thanks for being there with us. I'm going to talk to you about my paper recently published in Nature Scientific Reports. So it's entitled The 3D High Resolution MRI Method for the Visualization of Cardiac Fibrofatty Infiltrations. So basically, the context of this study is around the functioning of the heart. The heart is a mix between structural action and an electrical action. And in the world, you have a lot of troubles that could happen. For example, atrial fibrillation, which is most common and kills a lot of people, but also ventricular tachycardia, which can cause sudden cardiac death, and which is a big concern in the world. So the earth can be cursed with a lot of pathologies, and these pathologies show that there is a mix between electrical propagation and the structure of the myocardium. So we chose to use the MRI to characterize the cardiac structure because it's a methodology that can allow us to get several different contrasts. First of all, the link between the structure and function, you have right there a piece of heart of a rat, and you can see that the structure, the myocardium is in red, and you have some infarct areas with fibrosis in yellow. And the change of the tissues can cause some trouble. For example, it can just isolate an area of myocardium or cut the pathway for the connecting fibers called Purkinje fibers. These problems could be a source of local anisotropy, and it is possible to measure those areas with different MRI sequences such as DTI, STI, and in our case, method for fat water quantification and also magnetization transfer to observe the collagen. So we basically chose a pathology which is well known for presenting fat infiltrations and fibrosis, so which is a good candidate for our observation. This pathology is called ARVC, for arrhythmogenic right ventricular dysplasia, and it's an inherited heart disease, which involves the mutation of desmosomes. So it's areas on the surface of the heart muscle which link the cells together. And recent cohorts have shown that there are also many cases of left ventricle disease which are implied. So as the pathology evolves, you can clearly see that from the left area where the muscle is clean, you have some fat which is infiltrating the muscle and pushing things away. And during the replacement of the myocytes with fatty tissue, you have an inflammatory reaction which is here to clear the fat, but this causes some destruction of the following of the tissue at the vicinity and can lead to scar tissue such as fibrosis. So the objective of the talk and the paper is to present 3D high resolution MRI techniques to visualize both of these phenomena. Basically, for a bit of history, the fatty infiltrations were visualized in vivo with some different techniques such as late gadolinium enhancement, fat saturation, as you can see on the left. And for example, to observe smaller fatty infiltration, we had a 2D high resolution ex vivo, so spin echo experiments, which has been proposed to characterize fat. So as you can see here, but as it is at 1.5 Tesla, both MRI techniques are not really able to characterize the fat, or that can lead to misinterpretation because it's quite difficult to differentiate. So how the techniques have evolved? Warify separations are mostly known as Dixon techniques and are widely used to suppress fats in a clinical routine. So especially, for example, in abdominal imaging at 3T, but it's basically for this area, the liver, for example. So Dixon proposed a chemical shift imaging methods, and which implies the signal, the MO signal of water and fat. And time after time, his techniques showed some difficulties to sorry, I have trouble with dials. So we trouble with the hardware and magnetic field dependencies, which are correlated to the higher magnetic field. So initial implementation of this technique were not successful, and during the 90s, a lot of modifications of the technique were proposed, so including a 3-point method. And it was not until the early 2000s and the new Shimin techniques, algorithm for post-processing, that Dickson found its notoriety as a fat suppressor in a clinical routine. So basically what's happening here is you look at the chemical shift between the water and fat, and then you define an echo time which is going to tell that the first echo you're going to get is with fat and water signals in phase, and the second echo with a few milliseconds so that the fat and water are out of phase, and then you subtract these two images to get your water and your fat. But this obviously doesn't work today because of the inhomogeneities. So another technique, and the one we use called IDEAL, propose a different way. So basically, in a perfect world, you only need to get this echo with a 90-degree dephasing between fat and water, and then you can, from your signal, you can only get the real part of the complex signal to get the water, and the imaginary part of the signal to get the fat. But unfortunately, we are not in this case. So we need 2 more echoes, the 1 and 3, to make some calculations. And with the York call IDEAL, which is a post-processing technique, so which is based on the phase images. Here you can see that you have a clear delineation between the pericardial fat and the muscle in the middle, and it's different from echo to echo. And then when you apply the post-processing technique, you can isolate the water only and the fat only images. Here it is for the fats, but we want also to observe the collagen, so the fibrosis. So we use another technique. In routine MRI, as you may all know, we're applying a Larmor frequency and a pulse, which is primarily absorbed by the free water protons. And these protons then are going to begin a T1 relaxation process. And at this time, we are acquiring the signal to get the image. But during the process, the signal is released and absorbed to the lattice, so the surrounding of the free water. And in this case, you have 3 kinds of protons. You have protons which are bounded, and you have the protons included in the macromolecules. So when this energy is transferring, it's a phenomenon we call magnetization transfer. And if you decide, well, magnetization transfer here, and that's the image you get. So a normal flash gradient echo image. And if for any reason you decide to shift your frequency outside of the Larmor frequency for your preparation pulse, for example, then you're directly exciting the macromolecules, but the relaxation times are completely different. And as it happens in this way, from free water to macromolecules, the energy absorbed is going to spread through all other protons. So what is happening here is when you have your free water protons already saturated and you want to acquire your image, you won't be able to get all the possible pool of free water protons. So you have a smaller signal, and that's what we get here. So basically, we can then not really quantify, but we can then observe what is magnetization transfer effect here. So we need to acquire a first image with the magnetization, so MT pulse preparation here. So you get a darker signal for the muscle, and a reference image, which is here without any preparation pulse. And then when you do the ratio of the two of them, you get here an MT ratio, so MTR imaging. And this image shows, like, for example, in white, so region where there is no transfer, no magnetization transfer. So basically, because we excited the macromolecule pool, it's where it is. And the darker region here are the region where there is a transfer. So basically, region in white are the region where you can find some macromolecules in quantity. So to test this out, here is the material. So we use the 9.4 Tesla magnet with a 30 centimeter inner diameter, and 7-element transmit receive coil. So, and we applied this on 2 hertz, so 1 ARVC human hertz and 1 healthy or considered healthy human hertz. And we perfused them with some gadolinium and immersed in formalin to avoid any artifacts during the MRI acquisition. So the experimental protocol is pretty simple. We took both of the arts and we did a fat imaging at 200 microns isotropic, and a fibrosis imaging, so 2 acquisition with the MT preparation and without at 400 micrometers isotropic. Then we did the post-processing. So as I showed you, the hierarchical ideal to extract the water and fat only images. And we applied a ratio, which is called PDFF, which stands for protein density fat fraction. So it's an image giving the percentage of water and fat. So basically the percentage of fat in each of your voxels. And for the fibrosis imaging, we did the MTR image, and we zero filled the data to get to 200 micrometers isotropic. The problem is the time acquisition, which is very, very high for the MT. So we weren't able to do directly the 200 micrometer isotropic. And then the third phase, which is validation with histology. So we section at 6 micrometer in the transmural direction, and we use a Masson's trichrome staining for it. So to construct the PDFF 3D maps, what we did is we took the 3D volume of the PDFF and we get the cumulative histogram. Then we can see that we have basically 2 peaks, and we did a Gaussian mixing model to get the first peak, which corresponds to the water peak. And we define at 99.99% a threshold, which is TC, corresponding to this image, which is basically the full protein density fat fraction, where water is blue, and as you get higher, 200%, you get the fat, so in red. In the TC image, we have the threshold applied, and we only get the fat here, which is visible. We also took the usual Dixon threshold, which is 50% because of the limitation of the technique, and we get this image. So we don't have basically a strong difference. We did the same thing for the LC As you can see, is second peak is very, very smaller than the problem. Than the first one. We did also the Gaussian mixing model and applied the same threshold at the same positions. So the normal PDFF map and the one with our estimation and the Dixon classical one. So it leads to this. So here we can see for both hertz, the first echo of the gradient echo imaging, so the ideal sequence. Here you can see the protein density fat fraction maps with, again, water in blue and fat in red. So you can clearly see a difference, but you can also see with the green arrows some residual formaldehyde, which can cause some artifacts here. And on the third image, you can see the empty ratio. So where the LC Earth shows less macromolecules concentrated in the tissue. Now we have 3D images, so we can do 3D renderings. So here you can see pictures of both the Earths we imaged, and here in gray, the 3D rendering of the proton density fat fraction. So you can see in white the fat and in gray the tissue. So it's pretty relevant and pretty similar between the two Earths and their rendering. And if you cut in half in the long axis direction, the pathological Earth, you can see that we're going to study 3 characteristic areas for ARVC pathology, which is RV, so right ventricle free wall, right ventricle apex septum in this area, and RVOT, which is just below the pulmonary vein. These 3 areas are characteristic and are the first reached by the pathology in the right ventricle case of the RVC. So an overview of the results is still the same slice. So short axis slice with the right ventricle and the left ventricle. And if we focus on the middle part, we can see the water only image here, the fat only, and you can see some hyper signals. So following the purple, pink arrows. Here is the PDFF, where you can see on the green arrow that we have a bubble which been stuck in the sample during preparation and doing an artifact. And here you have the empty ratio image. So you can see some areas which seems to match the position of the fat image. So that's why we apply the threshold to make a superimposition of the 2 images and to determine that we have in white here, so the empty ratio, which shows presence of macromolecules, but also you have at the vicinity of this some fat infiltrated in the septum. So you can see both of the fat and fibrosis can be at the same position. And you can also notice some structural information about the pathology, such as the right ventricle is dilated. And the overlay, as I said, indicates position of the fat and fibrosis at the vicinity of each other. So now when we focus on the 3 areas of the ARVC hearts, so here in the LVOT area, you can see that on the white arrows, you don't have, so from here it's the pericardial, it's the endocardium. You can see that there's no more myocardium on these areas. And on the MTR, you can see that it's on the red arrow that there is transfer. So the little part of myocardium still there is filled with fibrosis. And that's why you can observe with the histological results on the right. So the green box is showing the area of the first white arrow. So you can see some in green, some infiltrating collagen, in pink, some myocardium, some muscle, and in white, some fat. And on the red area, you can clearly see that there's much more collagen than any myocardium. So basically, the RVOT, which is the area the most affected, is clearly presenting what we expected to present. And it's corresponding to the MRI results. Now, for the right ventricle free wall area, we have kind of the same results. So very thin myocardium still present in the free wall, and a lot of magnetization transfer. So it's quite difficult to see maybe on this side, but it is there. And when you superimpose the two modalities, you can see that you have transfer here and there, and the white outer area is fat. So same, when you look at the histological results, you can see, and especially on the red box, that there's no more muscle, only collagen. So the only thing that keep the blood inside the heart from going outside is collagen and fat. For the last part, which is very interesting because it's on the septum area, so you shouldn't find any fat because fats can't go up there. You still find some fat. So it's a clearly good indicator of the pathology. So here you get some fat in the middle of the septum, but you also get some fibrosis, but it's in a much smaller quantity as it is shown here on the histological results. So this result is pretty good because we shouldn't expect any fat, and there is. So to resume the results, what is important to see here is the fat ratio percentage we get. So we see, for example, for the RVOT that we have 76% of fat in the sample. And when we do the same observation on the histological images, we get something like 79 plus minus 9, which is in a good agreement. And it is the same conclusion you can get from the right ventricle free wall and the right ventricle apex septum, which is not negligible. For the healthy heart, you basically have twice less fat in the overall, and you can find also the fat ratio percentage between MRI and histology, which corresponding very well. So, oh, sorry. As I said at the beginning, we also have some papers showing that, some studies showing that the RVC pathology, which is basically known to start on the right ventricle, can also happen and affect the left ventricle, and it's what we are seeing there. So on the pathological heart, you have on the first line, slice 1 and slice 2 corresponding here. So something at the very base of the ventricles and at the middle area of the ventricles. And you can see, so in the base that you have, for example, on the PDFF, no hyper signal here in the green circle, but on the empty ratio image, you have something white here. So because it is not superimposing with the fat, we can see that, and we can say it's macromolecules. So basically, thanks to our observation with histology, we can say it's probably collagen. In the slice 2, so in the middle area, we can see that there is some fat in the left ventricle wall, and it's a little bit mixed with some collagen, but it's essentially fat. So left ventricle can also be affected by this pathology. So in conclusion, we did a 3D high resolution of 200 and 400 micrometer isotropic protocol to characterize the two fat and fibrosis. We used the hierarchical ideal to differentiate the fat from the myocardium and, by extension, the fibrosis. The MTR was used to differentiate fibrosis and myocardium. And we observed some fibrofatty infiltration at the vicinity of each other into the myocardium. So the results were also validated with histology and successfully applied to 2 human hearts. And to put the cherry on the cake, I would say it's accepted in scientific reports for publication. So I would thank all the people involved in the project to help me get these results. And I would thank you for your attention, and feel free to ask questions if you have some. Thank you.
Thanks so much, Kilian. Fantastic presentation. Congrats on the study as well to you, to Julie, Bruno, and all your colleagues. Do we have any questions from the audience? Yes, I see a question from Maxime. Very nice, Kilian. He's a little bit shy, as you know. I have one question regarding slide number 12. Are there any artifacts on the fat percentage due to B1 inhomogeneity, or is ideal robust to that?
Basically, ideal is working with with Ernst angle. So we should be, and the Ernst angle was applied corresponding to fat T1, and the PDFF especially is not part of ideal, but it's a post-processing trick which is calculated with only the proton density images. So we make some correction based on T1 map and T2 star maps to get only the proton density information, and then we do the calculation for the PDFF. So basically, the PDFF can be compared from one scanner to another, or the same results, the same hurt, for example, in different scanner should give the same results.
Thank you, Kilian. Thanks, Maxime, for your question. I see that Matthias wants to ask a question as well.
Yes, so thank you very much for this wonderful presentation. I think that's awesome what you've done here. And the obvious question is now, what do you do so that you know, Hubert Gaucher is going to use this clinically every day in every patient he has in the scanner? What's currently, I mean, you've already done 2 humans, right? So there is evidence of success. What is now needed in order to make this work in patients on a regular basis?
Basically, it's the same thing as all preclinical project. It's a resolution. The ideal sequence and the magnetization transfer imaging are both techniques that are already used in clinical routines. So what we've done here is we proved that it could be applied on much higher magnetic field. And the only concern is how can we get a much higher resolution in clinical, because it's the only limit we have here to observe some small structure, for example, here in the mid-septum. So it's just a question of resolution to me.
Can I bounce back on that comment? Kilian, a wonderful job, and obviously congrats to you and Julie and Bruno and all the people involved. But it's just to give a little bit of perspective on how these ex vivo experiments can be useful even in the clinic. Just for you guys in Lausanne who are mostly working on clinical CMR, how it connects with our scientific program and also our clinical program. So the idea of being able to obtain whole heart quantitative 3D data is extremely useful for us to personalize computational models, for instance. This is something that is very complex to do with histology, and to learn more on the 3D architecture of these structural abnormalities that is also difficult to describe on histology. But more importantly, there's also a patient care aspect of that. This 9.4 Tesla magnet is used, and we are considering using it even more broadly to do a post-mortem diagnosis of the cause of sudden cardiac death. So we are putting in place quite systematic scanning of every patient dying suddenly before the age of 40 or 35. I don't remember exactly the threshold we've been putting with, but so that we propose to the families who have a sudden cardiac death early that they participate to a research that is also patient care. So we would be using the methods developed by Kilian basically to do a postmortem diagnosis that we will then provide to the family, and that may have consequences on the way these family will be handled. For instance, we may perform transthoracic echo in all relatives, or and we will provide probably a cause of the death in many of these suspected sudden death. So there's also a clinical aspect. Ex vivo MR is not just a fantasy in the lab, but I agree that this spatial resolution would be very complex to reach in vivo, at least with MR.
Thanks for the insights, Hubert. Bastien, you have a question. Go for it.
Yes, you hear me?
Yes.
Okay. Thank you, Kilian, for the presentation. Can you show your slide with the model of the signal again? Can you explain me again how you model the fat plus water signal?
Here?
Yes. So water and fat is a real number. It's a magnitude, or
it is, yeah. It is longitudinal. Yeah, proton density of
so that water and fat is real, and then you extract the phase.
Mm-hmm.
But I don't understand why the phase of water and fat are the same, because they should have a different resonance frequency.
Yeah, basically, at the very moment you apply the pulse, everything should be, every spins should be in the same phase, because it's defined by the pulse. And then you have a phenomenon which is defined by the chemical shift. If you do the calculation, you know that every specific echo time, water and fat will be in phase, in total phase.
Okay.
And between these two times, you have some variation, because they don't have the same resonance frequency, so they will move. But you have periodically an in-phase situation, and you can.
Okay, and you measure at that time point where they're.
I can't really measure at 0, so at the time where the pulse is played, because I don't use any super fast sequence. But this time is repeated like periodically, so I can, for example, this echo is acquired at 3.5 milliseconds. So you know that you can play with that, because you know the rules that make the phase varying.
Okay. Okay, I understand more. Thanks.
May I add one point? That's Bruno Caisson here. Another point is that you have to understand that we're working at very high field. So at 9.4 Tesla, there is an other limiting factor that makes the Dickson technique difficult, is that the T2 star is very, very short. And initially, Kilian started to develop the Dickson technique. But if you need 3 echoes with in-phase, out-phase, and in-phase, then the signal-to-noise ratio you get at your third echo is so weak, particularly for the fat, that the phase information is not really accurate anymore. So that's another reason why he developed this particular technique, because then you can use shorter echo time, and that you don't fall into the problems of having very, very low signal-to-noise ratio on your third image.
Thanks.
Thanks, Bruno. It's great to see you. Chris, you wanted to ask another question as well? Chris?
Yes, just related to the potential translation to clinical or to in vivo even. I just wonder, so you have these beautiful super high resolution data sets, and you have obviously some measurements here of a fat fraction that you compare to histology. Have you looked at like retrospectively downsampling these data and see at what point do your numbers just not make sense anymore. So for example, that fraction of fat that was, I think, 70% and very close to histology, if you throw away half of your outer case space and double your pixel width, does that percentage still match, or does it go really far off? And have you looked at something like that?
No, I didn't, because I was too focused to get the highest resolution I could.
Of course.
Of course, but it would be interesting to look at this, but I don't really know.
If only to then be able to answer the, I mean, if only to tell us, you know, clinical translation people that, yeah, you know, it would work at this resolution, or no, it won't work.
Yeah.
It might be interesting.
Yeah, all right.
It's again, it's Bruno. It's difficult to raise a conclusion from only two hearts here. One with a known pathology where you have a huge fat infiltration. Another one, it was a very old patient, 83 years old, who was labeled as healthy, meaning that he has not established or not known cardiac pathologies. But then driving conclusions from the clinical translation on the spatial resolution in these two arts is difficult with only two samples. So I think this could be only performed if you have a sufficiently large data set. But we don't have 200 arts, human arts yet available. And then also, as Kilian mentioned, it takes quite a lot of time to acquire this data. And it's really a first paper on the method.
Matthias, you wanted to ask something as well?
Yes, when I was looking at your, you know, your model that Bastian was asking about, I was wondering whether the first echo, if that was a UTE echo, whether that would add anything for you or not.
It could be. It surely will, because at this time I think I'm not affected by, for example, magnetic field inhomogeneities, or quite less, because basically when I did Dixon, I had the logic that I play the pulse, and then I acquire the first echo. I am waiting the time for the second echo, but I was restrained by the gradients limitations. So I had to wait several cycles. And when you do this, you accumulate a lot of B0 inhomogeneities. So this sequence is coded as following. I played the first pulse, then I acquire my first echo, the shortest. Then I play another pulse, and I acquire the second echo with the nominal echo time differences. So it's something which is artificial. It's not three real following echoes. It's artificial because of the pulse. So I should gain some quality and some more facilities to apply the post-processing with using something like UTE. That's for sure. But the problem is maybe I've never used it, so I don't know. But maybe some troubles with some other artifacts at 9.4.
So maybe following this question, can you comment on the benefits and the applicability of your technique for low field MRI? Because we've seen a lot of people, you know, going back to low field MRI. Actually, the constructors are going back to low field MRI. Do you think your technique could be used for less than one Tesla system? Would that be useful in such case with using MT?
Maybe for the magnetization transfer, but I would say no for the Dixon techniques in general, because you win at having a higher magnetic field, because the time for a cycle to be done gets shorter. So you can get your last echo acquisition faster and shorter. The problem is if, for example, at 1.5 Tesla, it's the first echo, if, for example, you get it at 0 milliseconds, so at the pulse is played, the second echo, you need to wait 2 or 3 milliseconds. And the time is divided as you go higher in magnetic field. So if you want to go to low field MRI, the problem is your last echo will be very high and may be over some relaxation aspects such as the T2.
Thank you
because
very much.
the game is fat as a shorter T2 star or T2 than the muscle, and you want to observe it. So you want to have some signal. So you need to be as far as possible of the T2 star or the fat.
Very interesting. Thank you, Matthias.
Yeah, but however, you know, the T2 star is much longer at low field on the one hand.
Yeah.
On the other hand, the P0, as much as the P1 homogeneity, are much improved at low field, but the signal to noise is lower. So there is an interesting parameter space, and I think we don't know whether that will work to the advantage or to the disadvantage of these techniques yet.
Yeah.
All right, I think we're gonna move to the next speaker unless there is another question. Laure, I hope it's fine. We've taken a lot of time. We've triggered a lot of discussions. So let me introduce the second speaker for today. And thanks again, Kilian, for your presentation.
My pleasure.
So Dr. Chris Roy is a postdoc in the imaging team of Professor Stuber in Lausanne. And Chris has a lot of expertise in cardiac MRI. So from a sequence development side to a reconstruction side as well. And he has been very involved in developing new algorithms for fetal MRI when he was in Toronto, Canada. Chris is gonna share his work on motion compensated whole heart coronary MRI using focused navigation, or also called the FNAV technique. Chris, thank you very much for your time, and we look forward to your talk.
Thank you very much for the introduction. Everyone can hear me okay? Yep, great. Okay, so when we want to image the heart and when we want to image something like the coronaries, which are small and moving, motion is really an issue. And so in conventional imaging of the heart, we first want to deal with the cardiac motion. And this is done using ECG triggering. And we use this to limit our image acquisition to a resting phase, so where we think the cardiac motion is not moving very quickly. Second thing we have to deal with is respiratory motion. And this is conventionally done with some type of navigator. This can be an echo or it could be device driven, but essentially it's going to tell us when are we in an end expiration phase of our respiration, and then we only acquire data during this time point. And so if we do this correctly, it will hopefully allow us to effectively freeze the motion of the vessels or the structures that we're interested in, and therefore not have artifact that's degrading our images. Now, the downside of this type of approach is that we're only collecting data during a very small window of our acquisition. We have a lot of pauses where we're not really doing anything with the scanner. Additionally, if you have physiological variations, such as the heart rate's drifting or the respiratory position is drifting, this really leads to unpredictable scan times because we always have to wait for the position of the heart to be in the right place to image. And so an improvement of this technique is the idea of self-navigation. And in self-navigated data, we just acquire throughout either the entire respiratory cycle or cardiac cycle or both. In the talk today, we'll just talk about acquiring during the entire respiratory cycle. But the idea here is that by acquiring through that whole respiratory cycle, we now increase our data efficiency. And if we have some piece of data that we are repeatedly acquiring, we can then retrospectively monitor the respiratory motion and correct or compensate for this in some way. So this idea of radial self-navigation, or RSN, has been very successful in showing that we can do high quality images, isotropic resolution, while significantly improving our scanning efficiency because we're not just waiting to be in the right respiratory position. However, the existing approach for RSN coronary imaging was really limited to a one-dimensional rigid correction. So we're just correcting for the primary displacement in the SI direction of the heart. An alternative approach is actually to do a respiratory resolve reconstruction. So this is where we have imaging volumes at different respiratory positions, and then we use this algorithm XDGRASP to share information between these positions and therefore resolve the motion instead of correcting for it. And this has been shown to provide higher image quality than the simple one-dimensional correction, but can still be limited by uncorrected intrabin motion. So this is motion that still occurs within each of these respiratory resolve volumes, regularization, which is a part of the XDGRASP algorithm, and then in general, long computational times due to this algorithm. So the goal of the work that I'm presenting today was to improve the robustness of this 3D radial CMRA acquisition and reconstruction framework through a novel method for 3D non-rigid intra-acquisition correction of the data. So how does this work? So let's first just talk about how we do motion correction in an MRI, at least from a simple rigid correction standpoint. So if we have our K space, which is represented here by K and is acquired at a bunch of time points T, we can transform this K space if we know the coordinates of the K space. So this is the actual points that we've acquired, and we do know this if we've programmed our sequence correctly. And then by modulating the phase of this K space with the shifts due to motion. So this motion can be described in 3 dimensions as the shifts in X, Y, and Z at whichever time point T we've acquired this data. And if we know this motion perfectly, we can correct the K space by applying these phase shifts, reconstruct an image, and we're done. We have a beautiful image. However, we often don't know what this motion is, and so we need to estimate it somehow. And in this work, I use the well-established technique of autofocusing to estimate this motion. And so to begin, we start with this radial phyllotaxis sampling. So this is what we use for the radial self-navigated data acquisition. And it's been well established that we can apply some post-processing to this repeated echo that's oriented along the SI direction. And we get this nice respiratory signal here that is correlated very well to our respiratory motion. Now, the problem with this signal is it doesn't have meaningful units. So we're correlated to the motion, but we don't actually know how far the heart has moved in a millimetric sense. So what we do in FNAV is we decompose the motion that we want to correct into this respiratory signal that we know very nicely in time, and then we multiply it by these coefficients, which if we know these coefficients, it tells us the relationship between this signal and how far the heart is actually moving in these 3 different directions. And so what we want to do is we want to solve for these 3 coefficients somehow. And the way we do that is through this autofocusing technique. So beginning from a point where we don't know the coefficients, we just assume the heart hasn't moved at all, we can reconstruct an image. And as you can see, the structures of the heart are blurred because there's clearly underlying respiratory motion, but we're not accounting for it. We can then calculate an image metric. And this is just a mathematical metric that tells us whether or not the image is getting sharper or blurrier. There's a lot of different versions of this that we can use. In this case, we use the entropy of the gradient image. And as you can see, if we optimize this cost function here, this image metric, we start to estimate these coefficients that actually correspond with the underlying motion. And we minimize this cost function, and these optimized coefficients result in a sharpening the image at least over the region of interest where we calculate this cost function. And so what's interesting here is you can see that clearly we've sharpened the structures of the heart by accurately estimating the underlying motion. But because the overall motion of the heart, liver, lungs is not linear, we've corrected one part of the image while then blurring, for example, vessels that are in the lungs. However, we could play this exact same game where we shift where we calculate our image metric, and by now doing the optimization in a different region of the image, we end up with an image where we've now sharpened these structures of the lungs, but now at the consequence of blurring the heart. So if we want to account for all the different nonlinear motions that occur in vivo, we can apply this algorithm to all of the different pixels in our image. It's sort of a patch-based system. And what this then allows us to do is create a new composite image where each pixel in this final image reconstruction corresponds to the optimized corrected pixel due to applying this autofocusing algorithm. And so this is what is known as doing a non-rigid reconstruction through many smaller, locally rigid corrections. Now, of course, to apply this iterative algorithm to all of these pixels individually, this can take quite a bit of time. So we impose a constraint that is done in the following way. If instead of just putting the pixels in this composite image, we can also put the coefficients into these composite displacement fields. And what this means is that in this first, I mean, this is a 2D image, but in this first volume, we are placing all of our coefficients that describe motion in the X direction, and then the same for the Y and the Z. And because we know that this motion should be relatively smooth, we can then constrain this optimization problem that we have. So now instead of having to solve for every pixel individually, we can really limit the number of times that we need to run this algorithm and still have this nice composite corrected image. So to summarize how FNAV works, we have this respiratory signal that we get from the data itself. We don't know how it corresponds to the actual respiratory motion initially, but by solving for these coefficients on a pixel by pixel basis and constraining it by these motion fields, we can end up with an image that is very nicely corrected for respiratory motion. So with that, we performed a number of experiments to validate this technique and then applied in vivo. So this began with a really complex numerical phantom that simulates range of different respiratory motions and has realistic cardiac features. We then applied this to healthy volunteer data and then to a really large number of patients. So I was very fortunate to have access to a lot of data that was acquired over the years at CHUV with this radial self-navigated technique. And the acquisition itself is comprised of this prototype ESSFP sequence with the following parameters. So in terms of image reconstructions, we wanted to compare four things. The first is the uncorrected image. So how does this look if we do nothing? Then the first established, as I mentioned in the introduction, this 1D radial self-navigation technique. So just correcting rigidly for one primary direction of motion. Then the respiratory resolved images, which, as I mentioned, are usually an improvement on the 1D technique. And then finally comparing to the FNAV algorithm that I just described for this paper. And then to compare these reconstructions and really see the impact of these different image reconstruction techniques, we looked at how well FNAV could estimate the motion relative to ground truth in the case of our phantom data. And then we looked at vessel sharpness to see if these motion correction techniques are actually improving the image quality in terms of the coronary vessels. And then also perform some subjective image scoring and ranking. And then finally, we looked at how long these different reconstruction techniques actually take to give us some sense of what is the potential clinical use of these methods. So here we just have some numerical phantom results where these vector plots represent the amplitude of the respiratory motion in 3 dimensions versus time. So if you could see the ground truth simulation, and then what is estimated by FNAV matches really quite nicely with quite minimal differences here during peak respiratory motion. And if we actually plot all of these individual coefficients that we've solved for, in general, we have very high correlation and a nice slope when we compare the ground truth to the FNAV. We do see slightly more error in areas of the image where either the motion is so small that we don't really have sensitivity to correcting it, or where we have really discontinuous motion. But overall, when it comes to the main structures of the heart, we really get quite excellent validation of this algorithm. And this is really emphasized if we then look at what impact this has on image quality. So here again, we have numerical simulated data, and we're going to go through different levels of motion. So starting with relatively benign motion, so this is just several millimeters in only one direction, the SI direction. If our data is uncorrected, it is of course has artifact due to respiratory motion. If we apply the one-dimensional correction, we do a relatively good job at least correcting for the bulk motion of the heart, albeit still having blurred sections of the image where the underlying motion doesn't conform with this bulk motion. The XD grasp, the respiratory resolve reconstruction, this is just showing the end expiratory phase, does a really good job of then cleaning up all of this motion artifact by effectively freezing the respiratory motion in this one phase, with perhaps a little bit of blurring due to the regularization in the algorithm. And then the FNAV algorithm does a really good job of both sharpening the structures where the main motion of the heart is occurring, as well as in areas where the motion is slightly different. And all of these you can see relative to ground truth. If we then go to higher levels of motion, we start to see that the one-dimensional correction can't compensate for the fact that now we have not only motion in the SI direction, but also in the left, right, and AP directions. The respiratory resolve still does quite a good job. And then FNAV is very comparable to both respiratory resolved and the ground truth. And then finally, at very high levels of motion, of course, we have lots and lots of motion artifact. The one-dimensional correction can't compensate for it, whereas the XD grasp and FNAV still do a fairly good job compared to ground truth. We see a little bit of artifact in the FNAV reconstruction, but overall, the coronary arteries are still quite well represented. So with that validation done numerically, we turned to in vivo imaging. So here on the left, we have healthy volunteers, and on the right, we have patients. And these are just some different examples where here we can look at the RCA, and in general, the FNAV and the XD grasp do the best job at depicting the length of the vessel, with really FNAV in this particular example giving us the best delineation of the vessel throughout its entire length. And then the same thing can be observed here for the LAD, and here for the LCS. Similarly, in patients, we observe the same thing, where particularly in this patient example, where the 1D correction in the RSN was really not able to visualize the length of the vessel that well, or at least not that sharply, whereas we see really nice depiction of the vessel here with FNAV. And then similarly in these two examples showing both branches of the left system. And then finally, we have some more patient examples here with patients with disease where we can compare to X-ray. And in general, the take-home message here is, again, we see the best delineation of the vessel using the FNAV algorithm that we've developed. And it allows us to see these different pathologies, such as this stenosis in the left main, this occlusion in the RCA, this large aneurysm here, which is, because of its size, is obviously quite well depicted, no matter which correction you use, but is certainly sharper here in the FNAV image. And then finally, the same thing in this patient with Kawasaki disease. We really can well visualize this pathology with FNAV. And so to summarize all of this from a quantitative standpoint, we saw really high correlation between FNAV and the reference displacement estimates across all of our data sets. So this really shows us validation that in a phantom experiment where we know the motion that's going in, we're getting the motion out with FNAV. And this is allowing us to then correct the underlying data and have really sharp images as demonstrated by our measurements of coronary artery sharpness, where FNAV was significantly sharper than all of the other reconstruction methods. Additionally, we had a member of our team go through all of the 571 in vivo data sets, and he had the 4 different image reconstructions in a random order and chose which one was the best. And doing that blinded, he picked 444 FNAV data sets as the best out of 571, which was of course significant. Additionally, we had consensus grades between 2 experts that again scored these images and found that FNAV was significantly higher in scores than the other 3 techniques. And then lastly, while the FNAV algorithm does take a bit more computational time than the simple 1D correction, it's significantly faster than the respiratory resolved reconstructions. So, really talking about reconstructions on the order of 5 to 10 minutes, which is pushing us closer and closer to this being something that we can run in the clinic. So finally, just to summarize the entire idea, using FNAV, we can really measure and then correct for this complex 3D non-rigid motion, despite only starting from a very simple model of the respiration, which is this signal here. And this allows us to greatly improve our image quality while reducing the reconstruction time relative to sort of the best current reconstruction that we had for this type of data. And so what does this mean going forward? Well, because of this flexibility here, so the fact that everything begins from just this simple, repeatedly acquired case-based projection, we've actually been able to apply this motion correction algorithm to a lot of different data sets. So we have a bunch of ongoing projects that I'll just briefly talk about. This includes moving to free running data. So this is where not only do we acquire data throughout the entire respiratory cycle, but also throughout the entire cardiac cycle. And we're looking at this for both cardiac function, so dynamic imaging, as well as for just the best 3D CMRA image that we can get out of such free running data. I've also applied this to fetal data. So as Aurélien mentioned, my background was in developing methods for fetal imaging. And so we have some beautiful 3D volumetric images of the fetal anatomy where we can actually correct for the maternal respiration using FNAV. And then just other applications applying this to volumetric flow, to different types of mapping. And this comprises both, again, ECG triggered or the free running approach where we collect data throughout the entire cardiac cycle. So as you can see, a bunch of this work is going to be presented at the upcoming ISMRM, and then we have papers that we're beginning to write as well on these various extensions. So with that, I'd like to thank everyone on the team, and of course, thank all of you for your attention.
Thanks so much, Chris. Outstanding presentation, as usual. And I think your technique could be very useful to many people in Bordeaux, actually, because I see that Quentin is connected and is doing 3D acquisition of the heart. Well, this is not non-Cartesian, but this is Cartesian. So I think it could be useful. Would that work for Cartesian data, Chris?
Absolutely. So, I mean, conceptually, the idea of local rigid to create global non-rigid was first developed for Cartesian data. So this is certainly something that can work.
Very nice. Do we have any questions from the audience? I think Jess asked a question on the chat. Congratulations, Chris. Maybe I missed it. Newborn around. Congrats, Jess. But I didn't understand how your motion constraints help you reduce computation time for estimating the FNAV coefficients per voxel. We can also take it off.
Muted myself. Basically, that constraint helps to share the motion information across the 3D volume. So instead of calculating it for every pixel individually, we choose areas of our image, mainly the area surrounding the heart, to get what I refer to as candidates for these various coefficients. And this allows us to create something that I call the image bank. And this is talked about in the paper, but essentially we have a number of volumes that are all corrected with a different rigid correction. And then for each individual pixel, we want to pull the optimum pixel from that image bank. And because some areas of the image, for example, don't have much structure, it can be difficult to choose the right pixel from that image bank versus other areas that have lots of structure and give you a well-defined, this is a sharper pixel or a blurrier section of pixels. And so what the motion constraint does is it allows us to take areas of the image that don't have much structure and still keep the motion field relatively smooth, which is what we expect to happen in real life. So to answer the first part, it helps with computational time because we then don't waste time trying to run our algorithm in areas of the image that don't have any structure to begin with. And then it still keeps a realistic estimation of the motion field by making sure that it's smooth. I hope that answers your question.
Yes, she said. Any other questions? The people from Bordeaux, do you have any questions for Chris? Bruno?
Yeah, thank you very much for this wonderful talk, very impressive. I have actually two questions. The first one is maybe more philosophical. You're forcing by your system to have a very sharp image. Then maybe it's really well adapted in case of, sorry, I have 4 years son next to me. And the question is that, no, the question is that do you have any risk of creating or removing some information? In other words, if you have a structure that is not sharp in your image, by forcing the image to become sharp, can you evaluate the risk of creating an artifact?
That's a very good question, and I think it's something that has existed as long as these autofocusing algorithms have existed. And so the underlying assumption has always been, if you know the temporal evolution of the motion, but you just don't know its amplitude, the correct amplitude should always result in the sharpest image. Now, when I started working on this, it was using this approach to determine the cardiac motion. And in that case, we could very nicely show that the optimum cardiac motion always produces the sharpest image. And you can't have a sharper cardiac motion than the true underlying motion. And this can be shown in simulation as well as in vivo data. What's perhaps more a concern is that because we create this composite image where we as I mentioned before, we optimize the sharpness of each individual location. If we don't constrain this motion field, so if we have allow for very discontinuous motion, this might create artifact, because you can imagine for a very large motion, you may shift the underlying structure either in or out of the pixel. And this is difficult to evaluate with our computational metrics. We put constraints in place that we think work well, and certainly we've looked at a lot of data sets to validate this. But it is, of course, of concern, especially when you confound that with the fact that we do have discontinuous motion in real life. We have the chest that moves very differently from the heart. So we do have this kind of very sharp gradient of motion. And in the current data sets that we looked at, we have fairly good fat suppression. So we don't have a lot of signal in the chest. So we don't worry too much about whether or not we get that motion right or not. We're more concerned about making sure that the structures throughout the entire heart are corrected. So yes, artifact is always a concern, and that just requires a lot of validation of these reconstruction algorithms before we put them into the clinic.
Thank you. And my second question was, you show the different algorithms on your platform. Can you come back?
Yeah, of course.
It's this. I don't have the slice number, not before. This one, yes.
Yes.
Something that appeared clear to me is that, okay, you have very good performance in terms of being sharper, but if you compare, for example, the graph to the FNAV, the other point is that the signal-to-noise ratio, if you're looking at the liver, for example, looks very different. So it seems like the graph performs better or provides a better signal-to-noise ratio than the FNAV. Could you comment why do you see this difference?
Of course. So, I mean, this will always be something that occurs when we're comparing a regularized reconstruction to a non-regularized reconstruction. So in the XD-GRASP, we're sharing information between these different respiratory phases in an attempt to get rid of any streaking artifact that occurs because this is an undersampled radial acquisition. In the FNAV reconstruction, we assume that by combining all the respiratory data, we're no longer undersampled and we don't need to get rid of this streaking artifact. And so in the XT grasp reconstruction, a byproduct of getting rid of this streaking artifact is we also denoise these images a little bit. In the FNAV reconstruction, we haven't applied that. Now, we certainly could, and that's something that I'm working on right now for other data sets, is also having a compressed sensing step in addition to the FNAV. And this kind of gives you the best of both worlds. It keeps the structure sharp while denoising this a little bit. But of course, the trade-off is you really have to find the optimum point where you denoise the data, but you don't blur structures that are moving. And so that's kind of the trade-off in the XT grasp reconstruction, and it will become a trade-off of FNAV if we add this iterative denoising to it as well.
Thank you.
Chris, a comment that might also be a question. If our friends in Bordeaux wanted to use this FNAV technology, as so many do now in Lausanne, what would they have to do except buying you some Swiss chocolate? Or maybe some Bordeaux wine would be better.
That's it. That's all it is. I guess right now, I mean, acquiring the data, we can share the algorithms and we can do things offline. But that's certainly not as fun as what the next goal is, which is to implement this on the scanner. And before Davida comes in and yells the word fire, that is what we plan to do. So there he is. So yeah, we absolutely. I'm working right now on an implementation of this on the scanner. I think, Aurélien, you already have the radial self-navigated whip.
Yes,
is that correct? Yeah.
Yes.
And then for other applications, if you're not interested in the radial side, if you want to apply this to Cartesian data, for example, Aurélien has promised me when he's done writing his 100th grant for the week, he's going to acquire some nice data, and we will try this in Cartesian.
Absolutely, and I think it's going to be very useful again for Quentin as well, so we can put him in the loop. Mm-hmm. Hubert, do you have a clinical question for Chris?
Yeah, well, yeah. Do you hear me? Yeah.
Yes, absolutely.
Yeah. Not clinical, but it's a question I asked on the chat to Aurélien, but apparently he doesn't want to ask my question. No, because you're basically showing bright blood images, right? And it's related to the first question from Bruno. Since it's based on image sharpness, it's ideally suited to angios and bright blood images. But in your experience, since in your last slide you mentioned that you've tried it on different other methods, how do you think it would perform on either black blood 3D data sets or gray blood, like the 3D lake GADs we're acquiring? The blood pool is not that sharp, so would it still be working well, or do you have any experience on that?
Sure. So if we go back to, let's see here, sorry. If we go back to what defines whether the image is getting sharper or blurrier, it's this equation here. And traditionally, the image entropy, we think of it as being minimized when you either have all your pixels being bright or all your pixels being dark. And any shade of gray that's in between is going to be a non-optimal version of that cost function. Now, having said that, there's always different. So for example, for black blood, if you're just inverting the contrast, then this should work exactly the same way, because the metric doesn't really care whether it's it cares about the interface less than it does about
but when you said but what you said earlier concerns me. If you consider gray as an issue, and if you make gray disappear, that's a problem, because it's precisely what we want to map, the gray zones within dense scars.
Yes, but your gray zones, I don't think will become brighter or darker due to the respiratory motion. Maybe a lot of the gray zone we are mapping is just motion artifacts. So the only question I'm asking is, would that be suited to that kind of data set? Well, so for example, I think the closest we can get in our current applications is probably with the flow data that we have, where we have very poor contrast between the blood and myocardium, and yet we've still had success in measuring that motion. So that seems to work. But from a physics or theoretical standpoint, I don't see a reason why it wouldn't work. It could be that we have to adapt the cost function for a different contrast, find something that is better suited to that. In these other applications, for example, be it multi-echo or multi-T2 prep time, this has been a matter of, for example, in a multi-echo acquisition, choosing the echo with the best contrast to assess the motion and then applying that to the rest of the echoes because these are acquired interleaved. But that's very interesting. I mean, we'd have to look at some data sets and see what it does with these, especially somewhere where that there's something interesting that you want to map and be able to see how the respiratory motion affects it. But I don't, my intuition is that it wouldn't take something that is, if the true pixel underneath, if it's gray, I don't think respiratory motion will make it brighter or darker. It'll be a different shade of gray, I guess.
Thanks.
So we could use your Phantom actually to.
Oh yeah,
simulate
absolutely.
that.
Yeah, absolutely. You're absolutely right over there. Yeah, because
If
so
you
we
have
have in this numerical Phantom, we have the option actually of turning on or off some scar that we can give a different T1 or T2 contrast to, and then in this here we've used an analytical BSSFP model, but this can be tailored to whichever contrast or application you want.
That's
Amazing.
great.
Yeah, we should really try that.
Yeah, absolutely.
Any other questions?
Yeah, I have a comment, perhaps back to the question about Cartesian, Chris. One problem in the past when these navigator techniques started, and there was also navigator tracking, which I don't know many of you know about it, but there is a volume adjustment that is being done basically in real time to account for small motions within the gating window of the navigator. But switching that on, yes, it follows perhaps the coronary arteries with the respiration, but it turns simultaneously background structure into moving structure, which then leads to artifacts, right? And my assumption would be that this is much more of a problem for Cartesian acquisitions than it is for radial acquisitions. And so going back to the comment or the question we had earlier, would this also work with Cartesian acquisitions? I suspect there might be, some bleeding of artifacts of structures that don't move that then show up in the field of view. Can you comment on that?
Absolutely. So I think this ties a little bit to back to Bruno's question or comment about the XD grasp versus the FNAV here and this signal to noise. So yes, part of this decreased apparent signal to noise is due to the fact that we have not denoised it like we did with XD grasp. But this is not just purely system noise. It's also the noise of static tissue being shifted and then aliasing onto other pixels. So because this is if we go back to our composite image here, if you think here, so this pixel here that has been shifted to compensate for motion in the lungs, all of the other pixels that are shifted by some different amount have some degree of aliasing from the other tissues, if that makes sense. So for example, maybe a better way to describe it here, this pixel of the heart that has been shifted for cardiac motion has now aliased signal within this pixel from other structures that are not moving in that same way. Now, we are fortunate that in this 3D radial acquisition, which is already quite diffuse when it comes to motion, this just appears like additional noise on top of our image. In Cartesian imaging, this ghosting that we get from aliasing is going to be much more coherent. Now, what they showed in the initial application of this, which was developed at Stanford, where they had this Cartesian acquisition with sort of this spiral acquisition, which is very similar to what Aurélien uses, is that all of these composite patches essentially add some incoherence to these ghosts. So yes, you're adding artifact, but it becomes incoherent enough that you can denoise it with something like compressed sensing. And so I think out of the box, maybe if you imagine this exact same figure, but with Cartesian, the FNav is probably for Cartesian going to be even more noisy than you see here in the radial example. But we have many denoising algorithms that we could add to that I think would be able to decouple the structure from the aliasing. But of course, this all depends on the brightness of the signal that's moving out of sync with the heart. So again, if chest fat is not well suppressed, this aliasing might be more of a problem.
Any other questions? Chris, I see that we have a couple of people in the meeting who are developing AI algorithms. Mm-hmm. So you see my questions coming. Can you, or do you see a potential application of AI and deep learning maybe to maybe increase the potential of the FNav technique, make it faster, make it more accurate?
Mm-hmm. Well, I mean, of course, the obvious application to AI and motion correction, and we're already seeing it for the ISummerM, I reviewed 50 abstracts for the motion correction sessions, and I think 40 of them were AI, and they all kind of had the same recipe, which was, here are some beautiful images, we've corrupted them with simulated motion, and AI has made them nice again. And I mean, I'm really, without exaggeration, there was probably 40 of these that had that exact same structure. And so that blind application to an image that is blurry to de-blur it, I have a difficult time understanding how you can be, much in the same way we talked about earlier, how can you be sure that you haven't created some additional artifact? And so I think taking it a step backwards, and there were other abstracts that looked at this, of using AI to estimate the motion field and then applying that is, I think, at least a step that's a little bit easier to swallow, because you can really validate whether that motion field's correct. And then if you think about integration with something like we're showing here, AI could easily be the step that gets us to the first estimation of our coefficients, and then we apply the same type of constraints to the motion fields that we have, or we the parameter range that we need to search for with autofocusing is much smaller. And I mean, it could be, if you actually did that study, if you used AI to get first pass of the motion field, autofocusing to refine it, if the autofocusing never does anything after the AI, then clearly just use the AI. But it would be really interesting to see what it does. Does it improve it? Does it shift it? Does it get it closer to truth, further away from truth? And how robust would it be? So I think it could certainly make the whole thing faster by an initial condition, or it would be faster just by replacing the algorithm itself. And then, of course, all of the questions that Hubert had about different contrasts and how will it apply, all of those same issues will be there. So depending on what you train your AI on is probably going to affect how well it either de-blurs or estimates the motion. So these things, I think, are both competing and complementary. And it'll be really interesting to see how it goes. And then, of course, for the AI, you need to train it on something. So maybe we just train the AI to do as good a job as FNav, and that's the end of it. And we certainly, if we go back, these 549 patients, I think, are only a fourth or a fifth of what we actually have. We could apply FNav to probably 3,000 data sets right now, and then train a network to see if it can get a similar result. So, yeah.
Thanks for the insights. Anyone else? No, so then I think we're good for today. Chris, can you stop sharing your screen, please?
Absolutely.
I'm gonna show you a little thing. All right, so I'd like first to thank the speakers. It was really amazing. I thank you all for joining the meeting as well. I think it was quite a success. We had between 40 and 45 people, actually, way above what we expected. And just before I let you go back to your main activity, I want to invite you all to the next journal club, and that is going to be a woman journal club with 2 outstanding speakers, and they are going to share their work on free running applied to cardiac imaging. So this is going to happen on May 21st. But from now, wish you all a nice day and a nice weekend, and goodbye.